So share screen. Can you see that okay?
Yeah, great.
Okay, lovely. Let me just see, make sure that I can move that on. A few technicalities. Okay. Just to get started, I wanted to just refer that this information in this presentation reflects national guidance as well as the practice in our region in Devon, and the process may differ in the area that you're in. Also, this presentation is intended to provide just general guidance and raise awareness on PHBs and CHC, and I'm not allowed to give any personal advice or make any individual funding promises. Uh, all those queries, the individual queries, should be directed to your local ICB team. Just to let you know, ICB stands for Integrated Care Board. We've got the tendency of just using these acronyms and not saying what it means, so I do apologize in advance. So another acronym, CHC, so that stands for Continuing Healthcare. And also the other consideration that I wanted to put out there, when a personal health budget is set up by our team, the actual CHC process has started at a much earlier process. So if at any stage you ask me a question that I'm unable to answer, I will take that question away with me, look for the answer, and then get back to you, okay? I may not have all the answers for you today. So let's get started then. What are we going to cover? So we're going to cover what continuing healthcare funding is, and from now on we're going to be using the short word CHC. We're going to be talking about what are personal health budgets, and we're going to be using the acronym PHB, and how do the PHBs link with CHC, okay? Also going to be talking about a few common challenges that people may face. What is the difference and how they interact, PHBs, personal budgets, and direct payments. A little bit of myth busting around PHBs, and then we're going to move on to your questions. I know that this may seem like a lot, but we're going to try and cover it lightly so that you get out of here with some information that is relevant to you. Okay, so I came across an email the other day about a new video that NHS England has produced to explain CHC, and I've watched it myself, and I thought it was really good. So when I was invited to come here and talk about this theme, I thought it would be the ideal occasion to use that video. Before we move on to that, I just wanted to quickly explain what CHC is, even though they're going to talk about it in the video. It's a package of care that is fully funded by the NHS, and it's for adults, so people over 18 who have significant ongoing health needs due to a disability, a serious illness, or complex medical condition. Okay, we're only going to be watching the video until minute 6.29 because it then talks about different things that are not relevant for this specific, but you are welcome to check the whole of the video. This is linked on the presentation that is been made available. So let's have a little look. Can you still see that okay?
Yes, can
okay.
see it.
So I'm looking at a different screen, so don't think that I'm not looking at you, okay? So I do apologize. I'm going to put the video, and as I said, this seems to use very straightforward terminology and easy to understand, so I thought it would be ideal for now, okay?
There's no sound yet. Is there sound your end?
Yes, there is on my end. Is there not in yours?
No.
Nobody can hear it. Oh
No.
no, not very good. Let me just got the settings. Let me just go here. I'm not sure why the sound's not working. Is that for everyone?
Yeah, other people saying it in the chat.
Okay. Sorry, I
Yes,
didn't see that.
definitely.
I've never tried to play a video this way, so I'm not sure. Jenny, did you want to? Someone's saying you might have to share the tab directly.
Say that again.
Someone is saying
rather than the whole screen.
Yeah.
The other thing is that you can, if you go off of share screen and then go on to share screen again, at the bottom left-hand side, there's a little tick box which says share sound as well.
Oh, yes.
Oh, thank you, Jenny.
Dependent on a particular
can hear
disease,
it.
diagnosis, process, also known as NHS CHC. What is NHS CHC? NHS CHC is a package of care arranged and funded by the NHS that you may be entitled to receive due to disability, accident or illness. Eligibility for NHS CHC is not dependent on a particular disease, diagnosis or condition, nor on who provides the care or where that care is provided. It is for a relatively small number of people aged 18 and over with high levels of need, known as a primary health need. If you are under 18, there is a separate framework for children and young people's continuing care, which is not covered within this video. How does the NHS CHC process work? There are several stages in the NHS CHC process. They are assessing eligibility, planning your care package, and regular reviews. It is important that at each stage you and your needs are put at the centre of the process. Your local Integrated Care Board, or ICB, is the NHS organisation responsible for arranging the provision of health services in your area. They have a duty to assess and decide if you might be eligible for NHS CHC, and, if you are, to then work with you to agree the appropriate care package to meet your assessed needs. Stage 1. The NHS CHC checklist. The assessment process usually starts with a screening process called the checklist, completed by a trained health or social care professional. The checklist covers various aspects of your health and care needs and helps to show if you require a full assessment for NHS CHC. The checklist will be offered to a lot of people to see whether they need a full assessment for NHS CHC. It's important to be aware that the majority of people who have a positive checklist are found not to be eligible for NHS CHC once the full assessment has been done. If the checklist is negative and you disagree with this, you can ask the ICB to reconsider. Stage 2. NHS CHC Full Assessment. If the checklist is positive, a multidisciplinary team, or MDT, will then carry out a full assessment. The MDT is a team of at least 2 people from different healthcare professions, or 1 healthcare professional and 1 person responsible for adult social care assessments. Where possible, the MDT should have been involved recently in your assessment, treatment, or care. The team will talk to you and, if you agree, other people who support you, including a relative, friend or advocate, can sit in the assessment with you. They will review your medical and care records and gather information from other professionals and specialists involved in your care. They will consider all aspects of your needs in relation to 12 care domains, for example, breathing, mobility and nutrition. You should be invited to attend and participate in the MDT meeting This meeting may happen face-to-face or virtually. You can discuss with the ICB how the MDT meeting is held. The MDT will complete the Decision Support Tool, or DST. This helps the team decide whether they think you have a primary health need. To guide this decision, the team will look at all your relevant needs in relation to 4 key characteristics: nature, intensity, complexity, and unpredictability. The MDT then recommends to the Integrated Care Board whether you are eligible for NHS CHC or not. The ICB should usually accept the MDT's recommendation. The NHS CHC assessment process should, in most cases, take no longer than 28 days. If you are eligible for NHS CHC, the NHS becomes responsible for meeting your needs. Any support from existing local authority arrangements will draw to a close. If you are not eligible for NHS CHC, you can ask your ICB to review its decision. Your ICB should tell you how you can do this. You could be eligible for funded nursing care provided by the NHS to care homes with nursing. Alternatively, you could be eligible for joint packages of care, where the NHS may pay for part of the package of support. These are described later on in the video. Stage 3. Planning support. If you are eligible for NHS CHC, your local ICB is responsible for planning and sourcing your package of support based on your needs. This includes what help you get each day, where that support will be given, and who will deliver it. Your wishes should be at the heart of your care plan and package of support. You may choose to have a personal health budget. You can find out more about this at www.england.nhs.uk/personal health budgets. Stage 4. Reviews. If you are eligible for NHS CHC, you should have a review within 3 months of the eligibility decision to make sure that you're getting the support you need. Further reviews should be undertaken at least once a year and may be more frequent depending on your needs. The main focus of these reviews should be on whether the care plan still meets your needs. Sometimes, this may mean that a reassessment of your eligibility for NHS continuing healthcare with a multidisciplinary team is required. Fast Track Pathway Tool for
Just sharing my screen again, just coming out of the video. So we're going to move back to the presentation where we were. I hope that was clear. I still need my other presentation here. So we're going to be just recapping on the video. CHC funding is based on how much help a person needs because of their health, and not just their medical diagnosis. It's all about how complex, serious, and unpredictable your care needs are, and not because you've got a specific condition. Just as an example, if a person was to have, for example, autonomic dysreflexia, you're not going to get CHC because you've got that specific condition. It's how all the conditions and all of the health needs interact with each other. Okay, and then the eligibility is decided through that checklist, and if that is positive, then it moves on to a decision support tool, which is completed by a team of professionals that look at a series of rules called the National Framework. So you've seen the process in 4 steps. Starts with a checklist and goes on to a full assessment if the initial one is positive, and then the decision-making process, then a review, care plan completion, and monitoring and reviewing. Just wanted to add here, because it didn't say in the video, when a full assessment is undertaken, there are 12 domains that are assessed, and then the needs are given a mark. So I think they are on priority, severe, high, moderate, low, and no needs. And at the end of the assessment, all those marks are added together, and then it gives you an outcome which will say whether the person is eligible for continuing healthcare funding or not. And additionally, if this is not conclusive in itself, they will look at those 4 key characteristics that were mentioned in the video, such as unpredictability, nature, complexity, and intensity, which means that they look at how all the health conditions interact with each other and how it affects the individual before making a decision. Okay. So what does CHC actually cover? So it can cover care in your own home, or in a care home, or in another setting. And also things like personal assistance, nursing or specialist care, equipment, therapy, support with daily living, essentially anything that will cover the health and well-being needs. Okay, so we've covered the component of CHC, so continuing healthcare funding, and how the personal health budgets come about in this. How does it link? So if you look at CHC as sort of your funding, the PHB is the way that the funding is going to get to you via personal health budget. Okay, so you see it as a puzzle. PHB is the delivery mechanism of the CHC funding. So PHBs have been around for quite a while, actually. So since October 2014, people eligible for continuing healthcare funding were given the legal right to have a personal health budget. And since 2019, they became the default delivery model for NHS CHC funded home care. And in 2025, we do like to think that PHBs can offer great choice, flexibility, and control. Now, these are all great terms, and you might hear the same with social care direct payments, and that's the aim to achieve. In reality, it's not always possible, and part of my role is to also make sure that we get to that. But we are all aware that that's not always the case. So I'm not going to be painting the world pink, because it isn't, unfortunately. And a PHB is also not all great, because we still have some challenges, but we try to overcome them, and we ask for feedback from our budget holders, and just to see how we can improve, really. So what is a personal health budget? It's an amount of NHS money that is allocated to an individual to support their health and well-being needs. So you've had the assessment, the DST, and it came out that you are eligible for continuing healthcare funding. And then we need to be thinking about, how are we going to meet your health and well-being needs? And it needs to be stated in your care plan how you are planning on meeting those health and well-being needs. Okay. So the personal health budget is going to allow you to manage it in a way that suits you, really, with whatever you need, whether it's PA support, whether it's agency, any equipment, alternative therapies. So it works in a similar way to personal budgets and direct payments, which allow people to manage and pay for their social care needs. And again, with the aim to provide more choice, control, and flexibility in meeting the individual's health and well-being needs. Who can have a personal health budget? Can anybody have one? So firstly, for adults that have been made eligible for continuing healthcare funding, including fast track, and children with continuing care funding. This terminology is being discontinued, and all age continuing care is taking over. So instead of saying adults and children, we're going to be using all age continuing care. We also have personal wheelchair budgets, people who are referred and already registered to meet the eligibility criteria within their local wheelchair services. So this is something that in Devon particularly, our team do not process these types of PHBs because that is commissioned to a different organisation to deal with that. And people under the care of the mental health team who are eligible for Section 117 aftercare. I just wanted to briefly mention that we have an integrated budget that is working really well for a Section 117 case. So there's 50-50 funding from the local authority and health. And this person is completely changed. They've got a dedicated team that has been built with the support of mum mostly, and a really, really good team of PAs that were upskilled in how to deal with this person. And it's just amazing to see the progress and how settled this person is. So yeah, there's still hope out there. Sorry. So how can you manage your personal health budget? There are three PHB types, but before we go on to them, I just wanted to briefly mention some numbers that came from NHS England in 2024. So they claimed that 15% of personal health budgets were delivered as direct payments. 80% of personal health budgets were delivered as notional budgets, and 5% as third-party budgets. So we're going to be looking into these briefly. A third party is really ideal when a PHB recipient does not want to manage a direct payment or to take on any employer responsibilities, but they can still be involved in choices as much as they wish to. And these choices are around training, recruitment, and how you want your care to look like. So currently in Devon, we've only got one through third-party provider. So this gets a little bit tricky to arrange, and it's probably one of the most complex ones to kind of set up from our perspective. Then we've got the notional PHBs that are usually set up by the funding body with mostly providers. It does give you less control and flexibility over your care though. But on the other hand, it does free you from having all the employment responsibilities. And then a direct payments, that is one way of managing these budgets, is when you get the money directly to buy the agreed care and support that you need. Similar to social care direct payments, we do set it up as either a managed account or a prepaid card. Managed account, you've got a payroll provider that will support with all the associated payments to meet your healthcare needs, health and wellbeing needs. And with the prepaid cards, you will get a card in your home address and you will manage those payments yourself. We're going to be talking a little bit more about the direct payments in the next few slides. So how can you actually use a PHB? I've spoken to many different people and they ask me, oh, Anna, can I use my PHB for this? Can I use my PHB for that? And then we have a conversation. How is that going to meet a need that you've got in your care plan? So essentially, that's what you need to be asking. You should be using your PHB to purchase support, whether that's via a PA or an agency, training. It could be related to activities, respite, any assistive technology, complementary therapies. But what you have to take into consideration is that those needs need to be stated in your personalized care and support plan, because that's just the way the PHBs work. They're a lot more prescriptive than the social care care plans, and not as user-led and personalized. And we'll talk a little bit more about that further down the line. Obviously, you're not able to use your PHB for gambling debt repayment or other NHS treatments, because that's, you know, the NHS treatments are already free. I wanted to give you a few insights in terms of stories that we've got in with our PHP recipients. This is not feedback that we've received from individuals themselves. This is something that we've collated as a team. So a PHP holder employed a PA not just for personal care, but also to support them just to move on with their life and just have a normal life as any other person would, you know, to accompany to social activities, medical appointments, and to make sure that they promote their independence and mental well-being as much as they can. We've got some people that instead of booking traditional block respite, they arranged a short tailored break, and they used a local support worker to make sure that when they go on respite, their beloved person is well looked after. So some individuals have included funding for therapies and gym membership as part of their health plan, because that can be seen as increasing their mental health and their well-being. I just wanted to put it out there, not every ICB will agree to this, and this is subject to you having a conversation with your CHC assessor or the local PHP team or your local ICB, okay? And some PHP holders use their budget to employ, for example, a lead personal assistant, and they can support with all the PHP administration. What you have to think about is that you don't have to do it alone, okay? So that was just a little bit of an overview of how PHPs are being used in Devon. So what needs to be in place for us to get started? Really is the personalised care and support plan that is going to dictate, or is going to have the information of what you can use it for. And then we need to seek budget agreements. We need to make sure that there is clinical oversight. And when we talk about clinical oversight, this is what I was saying about PHBs being more prescriptive, because usually the individuals have got a primary health need, so that's usually associated to complex conditions, and there are what we call delegated healthcare tasks, and that means that a team in the community has delegated a task to somebody that's looking after that person at home to perform that task. And when I say task, it could be, for example, suctioning. So the team may delegate that task, and then obviously we need to get training in place for the personal assistants to be fully up to date and competent to deliver that task to the individual. And then last but not least, appropriate support. And when we say appropriate support, that means from direct payment support services, so your payroll, your insurance company, your PHB teams, your CHC assessor, and whoever you can get on board to support you. So you've got the CHC assessor involved, and you can also have a family representative like we've seen in the video. There are quite a lot of responsibilities that come when we talk about direct payments, and I understand that some of you already hold a direct payment, so this won't be any news to you. So I'm just going to quickly scroll through that, and I may come back to it if you feel that it's important. So how are PHBs monitored? In the same way as social care direct payments. However, I did say that PHBs are a little bit more prescriptive, so that's why we need to, when we're auditing the PHB, to kind of see whether a certain expense is in the care plan and whether it equates to what we're seeing in the transactions. So most of the time they are. I'm not going to lie, sometimes it does feel like policing people, but I like to think that we're working towards being more flexible in terms of how people manage their PHP. If people have got a prepaid card, we access their records and may query any transactions outside of the normal. All I would say is keep your records, keep your receipts, and all the communication that is associated to a specific query. So these are some of the common challenges and how we support them. Your health may change. What shall I do? I'm unable to find staff or providers. Who shall I talk to? How much flexibility can I have in my PHPs? What are the rules to manage my direct payments? How am I going to manage the funding? And also some of the challenges that we've been informed is the coordination between the funding bodies to determine the appropriate source of funding. So sometimes there can be some battles, and just to say that I acknowledge that, and that's not nice. And one of the questions that has been responded contains information about this. So there are a few differences between personal budgets and personal health budgets. I'm just aware that I've been talking quite a lot and we need to close for questions soon. So I'm just going to talk a little bit more about this, and then we move on to questions. We've talked you've seen in the video that the eligibility criteria for personal health budgets. So in this instance, for social care, the process starts with the care needs assessment. The relevant professionals will come together and see how an individual manages the everyday tasks. And I'm aware that people can top up with personal budgets. In personal health budgets, you shouldn't really have the need to top up because your funding should meet all your health and well-being needs. What I would say as an example, if you think that your care plan says that you need a personal assistant, and then you think that you want a nurse, that is a want rather than a need. So in that instance, you are able to top up your care for something that is particular to you and that you wish to have. So some things remain the same, such as personalization, choice and control, and some things are different, such as the overall culture in PHPs. As I said previously, PHP culture is more clinical and risk conscious because of the medical tasks associated and the training that the PAs are required to have, whilst the social care direct payment is more, I would say, empowering and flexible and user-led. But, working every day to bring the personalization and ethos of social care into PHPs. So that's in short. Just recapping everything that we kind of said, what is the difference between a personal health budget, a personal budget, and an integrated PHP and direct payment? Personal health budget relates to your health care and support needs. The personal budget is for social care and support needs, and the integrated budget is for both your healthcare and support needs and your social care needs. And then a direct payment is the one way of managing these budgets. Okay, that's when you get your money directly, so you can manage the your needs as you see fit. Just prior to going into our questions, sorry, didn't need to reveal that. You only qualify for CHC if you have a physical disability or need nursing care. You're probably thinking, is this right? Is this not right? Not really. CHC is not just for people with physical or nursing needs. CHC eligibility is based on need and not a diagnosis, okay? PHPs are not only for employing PAs, they can fund anything that meets the assessed health needs. It's too complicated to manage a PHP. Yes, it can be complicated, but many people manage with support. All you got to think about is a PHP with a direct payment. is one way that you will get control over your care. And these are the questions that we've received in advance, and they have been provided with answers. So I will leave it now and open for questions, if that's okay with everyone.
Thank you so much, Anna. We have had a lot of questions.
Did we? I didn't see.
Yes, great.
Relying on you.
No worries. I'm going to go through as many as we can, but thank you so much. That was absolutely fantastic. Okay, so the first one is, if someone is in receipt of a package from social care and moves across to CHC funding, would you expect everything to be moved over with them? For example, transport funded through social care and respite, should all these things continue?
Good question. So they could transfer to start with to make sure that you get continuity of care, but then you will have a new care plan developed with your CHC assessor, and then we'll make sure if that is a need that you have, and it continues, yeah, it will be met by CHC, by your PHB.
Thank you. This one you did answer at the end, but is it realistic for someone with a multiple neurodivergent person without a physical or learning disability to get a health budget, or is it only for people needing nursing or other care for physical conditions?
Absolutely. It's all about how the conditions, like I said, interact with each other and affect the individual, and that obviously is reflected in the decision support tool.
Thank you. Can you get a health budget to get services that should be available through one's local NHS but aren't?
I'm not sure what specific services we are talking about here. I can give you an example that happened in Devon and see if that helps. So when I talked about the delegated healthcare tasks, the NHS professionals should go out and train the PAs and make sure they are competent to deliver that healthcare task. However, that's not always the case, and not all the teams in the community recognize that as being their role. So what's been happening is that we have to source a third-party provider to deliver that training to the PAs. So in that case, I would say, yes, we should be fulfilling that via an NHS services. But because we are unable to, and because a lot of work needs to happen in the background to change how those teams see themselves and in terms of job description and things like that, yeah, we need to source that.
I think things that come to my mind are things that have perhaps been cut to the bone, or I'm thinking things like hydrotherapy, physiotherapy, orthotics, things that perhaps do exist but have limitations or have even been cut entirely.
Yes, so I'm going to speak again from our patch and just be worried that this needs to be discussed in your local ICB and with your CHC assessor to make sure that that is authorised in your area. But we do have some PHBs that have got hydrotherapy, and this is after evidence received from the GP and the relevant professional to say this person does actually benefit from the hydro because of this, this and that. So we're not simply funding it, we ask for a rationale why we should do it. So as I said, it is quite prescriptive, and making sure that we get that medical background to before we allow any funding.
And what happens if you can get the service but it's very restricted? So again, often in my area, you can get physiotherapy for say 4 to 6 sessions, but the doctor might say that person would benefit from it on an ongoing basis. Would that be something that would be considered?
Yes, we do have a few cases that, again, we looked at the GP and said, can you evidence the need, GP or the physio? Sometimes we do get letters from physios, but we would be looking at getting that recommendation from the healthcare professional to say, yes, this person really needs to have this in place, and it's having much impact in their health and well-being.
Okay, thank you. Is continuing healthcare meant to cover social needs too? And what is classified as social care beyond the funding of a PA or support worker?
So I would look at CHC as kind of a holistic thing. CHC, health and well-being. So everyone has got social care needs, and despite when you get eligible for CHC, you kind of forget about social care needs because they kind of come into all one pot and NHS funds it all. There's no splits here and there. There's no contributions. There's nothing. So I would simply look at it as holistically, a person has got needs that just needs funding.
Thank you. Do you think that CHC funding can be seen as more restrictive than direct payments? So, for example, I know someone that had direct payments and was able to travel and have PA support, and when they moved to CHC funding, that was all completely stopped. Is that normal, or was that just an unlucky circumstance?
I would say that perhaps because the PHB is not, I did say it was more prescriptive and less kind of looking at, so social care, they say, here's your money, make sure that you manage it to meet your social care needs. And people go and kind of, I don't want to say that they do what they want because that's not what happens as long as they meet their needs. But in terms of CHC, with a PHB, we would have to evidence that need prior to funding it. I'm not sure if that completely answers the question, but it could also have to do with area and how the need has been approached and discussed.
Right. Yeah, okay, thank you. If you are receiving joint funding between the local authority and ICB, who does the review, or do they both do them?
Say that again, Jade.
So
Please.
if the person is getting joint funding between both the local authority and the ICB, who would lead the review, like the yearly annual review, or would they both require, as in?
Yeah, normally, sorry to interrupt, normally it would be the local authority to lead the review. Yeah.
Okay.
So just to add to that, in terms of that case, that example that I gave for the section 117, just as out of process, NHS and the ICB have been asked to lead on all the reviews for that particular individual due to the complexity of the health needs. But that was, you know, a one-off case, usually led by the local authority. Okay.
Thank you. I think a couple of questions are around, once you've been given a personal health budget, there's a lot of fear of it being taken away. And someone has asked during review that it might be a struggle to keep a personal health budget. Have you found that to be the case?
I wouldn't say it's a struggle to keep the personal health budget, but I would say that your needs can change. And that's what the reviews are for, to make sure that your needs are still the same or it needs adjusting.
I think people are finding pots are tightening. This is across the board in both personal health budgets and direct payments. And so people, we are being reported to from our members that without your needs decreasing, suddenly things are being removed from care plans, suddenly hours are being reduced or fought over. I think there's a lot of that anxiety around that happening. I know it's not something you can answer to say, oh no, that definitely won't happen or it will happen, but I guess it's just about, I think there's a lot of fear around that.
That's very fair to say, Jade. Let's be honest, it's all very much led by budget constraints, unfortunately, and it's sad to say this, but that's what we're facing. We still need to be there and say, actually, the individual needs to be put first, and as much as we can. There are a few things that we can consider. So just being really honest with you, we do not add contingency funds in PHPs in our area at the moment. Well, it's been since February 2024, because what we've seen is that it always accumulates in the account and they're not being used. So what we've decided to do is we allow for 8 weeks in the budgets, and if people need it, just let us know and then we can top it up. But that's there for emergencies and if they need it. And there have been cases of, you know, people have got a component for hospital travels that they need to attend with a specific consultants, and that is funded via the PHB. We've removed that component because most of the appointments are now online. But if they do need that face-to-face funding, they just come back to us and we'll put some funds in. So it's not like it's being taken away, it's not being projected in the funding.
Okay, thank you. The next question is around, there have been a few reports, particularly in Sussex, and I did email you about this, that it's been told that personal health budgets are being paused. And I thought it'd be interesting to ask you, because others may be hearing the same thing or in other areas. This is specific to CHC funding, and I think both expressed surprise because I thought it was a legal entitlement to be assessed for CHC. So I just thought it'd be interesting to get your thoughts for everyone in case they're facing a similar situation where they're being told then no more personal health budgets might happen.
I was very surprised when you told me that, because from my perspective and my understanding, NHS England is very much for let's do direct payments, let's do personal health budget direct payments. So I'm very much surprised why that is happening, and I'm not sure if it's something to do with the team in the area that's struggling with something. But you know, there are several networking groups with PHBs, and if that is the case, we're welcome. They're welcome to kind of gather and see how things are, you know, working well in different areas of across the country and mirror that, and we can chat about things, but not really refuse it to people.
Yeah, it does seem very strange. Thank you. So there's just been an update in the chat. My case manager said it's because of NHS England changing that personal health budgets are being paused for new applicants. So it's a pause rather than stopping. But if other areas aren't pausing because NHS England has just been they've been changed. I can't think of how to defunded, I suppose, or they're being moved into a different way, aren't they? Seems odd.
Not that we've received communication. At the end of the day, CHC is statutory, so we would not be stopping our services.
Yeah, thank you. Someone has asked, is there a legal framework requirement for the minimum or maximum number of reviews and assessments within a calendar year? I think they're feeling like they're having too many, and they're wondering if there's anything they can do to stop how many reviews they're having.
Very good question. I am unsure if it's one at a 3 monthly review after setup and then yearly, but I can double check and get back to you on that. Okay.
Thank you very much.
And the other thing I would say on that, they name the reviews differently. So they can say it's a financial review, this is a clinical needs review, and this is another review. So it could be that the person is experiencing a lot of reviews, which is not really fair, by the way. I'm not excusing anything, but it could be because of that.
Yeah, I mean, I've experienced that from direct payment side. I used to have one review. I wouldn't even say yearly because they were so behind. Since then, they've brought in financial reviews and they've brought in a monitoring team to have a monitoring review. So it has gone from one every now and then to three potentially regularly. So it can feel a lot when you're under such scrutiny all the time. So again, I do feel this is around finances and then just from my view, potentially looking at ways to claw back. Okay, anyway, we've got so many to get through and some are really interesting, so I want to ask. Can you confirm if the new team all age continuing care now means that one team manages, or will it still be split nationally into adults and children?
I cannot speak for other patches, but in our ICB, what we're doing is we've got a head of all age continuing care, and then we've got sub people that manage adults and young people, and then there's a person for transitions. Does that help?
Yeah, thank you. I'm just saying in the chat, we'll probably need to stop questions coming in because they're still coming in as we're talking. And there's 2 minutes left.
Okay.
Yeah, if
I just wanted to say, if you want to email me the questions, I'll do my best to get back thoroughly as I can. Just where I'll be on an annual leave period, so that I can respond from the 9th of July onwards. Okay.
Thank you. There's a couple then I'm going to skip. Not skip your questions, by the way. I'm going to skip to get the last couple in, and then the rest will be answered in by writing, if that's okay. But something that's coming up a lot, and it's again something I just emailed you about, but I know a lot of people are struggling with this, and it's these they're called different things: activity logs, daily logs. People are suddenly being required that their PA writes down these logs of what their PA are doing. There has been a lot of distress and anxiety about this, and I understand from your response that it's something they can ask for, but I guess it's like, but how can people push back? Why is this suddenly needed? You know, some people have had budgets for 10, 20 years, and suddenly it's being put forward as, you know, it's impossible to continue your budget unless your PA is writing down that you had a drink at 2 o'clock, went to the toilet at 2:15. And I guess there was a lot of frustration about this. I just wanted to get your thoughts on it. Obviously, I'm biased. You can tell by
It
my
was really,
question.
yeah, it was really interesting to see your point of view, Jade, because, you know, when we talk about this as a team, we don't really think of that point of view. So we've consulted NHS England to see what their point of view was on this, and if they had any templates that we could provide to our PHB recipients. And at the time, they said, well, this is not something that is mandatory, and they didn't provide anything. So it's very much blasé, not really an answer. So just again, talking from our patch point of view, we recommend that people have it in place, and I will explain why. So if a package of care comes to us and says, oh, this person now needs has moved on from a sleeping night to a waking night, they're being supported constantly, and now these nights need to be 2-to-1 instead of 1-to-1. So we may ask for the records just to see how are the nights. Is this something that is isolated because the person's condition has deteriorated in that period of time, or is it because the person is actually you know, just really going downhill quickly? We just need to understand whether the funding needs to change provisionally, or if we need to put some more money in that specific period of time, or if the needs are changing, you know, for good. So I would say, from my perspective, and from my experience, that's how we would ask for it. Very, very rarely we would ask for it, but you know, can only speak from my experience.
Yeah, I guess from our side, this is something I've just experienced, and I'm not on CHC funding either. I've just had it again after 12 years of direct payments. I've been asked to keep one, and I basically said no. I said I would keep one for 2 weeks so you can review my current situation, but to do it on an ongoing basis just feels so intrusive. It feels like a pointless waste of time. This is just my view. I'm not attacking what you're saying.
No, absolutely.
I also feel there's a lack of trust because, you know, we're already following our care plans, we're already doing timesheets. It just feels like one more thing we're supposed to do to prove that we need the help we've already been given. So I guess, I just wanted to feed that back, I think, because anyway, we can sort of push back on that being, you know, like you're saying, if someone is saying there's been a change of need, saying, well, can you keep one for temporarily, I think can be a fair statement, so you can show that need. But on an ongoing basis, it just feels very frustrating.
You can ask the reason why the records are being requested, and I know they will say it's good practice. I can anticipate that.
Yeah.
And I would be open and honest and say exactly how you feel. I think being honest about the situation is the best policy, really.
Yeah, thank you. Do you mind if I very rudely ask one more question? I know we've just got past time, but it's something that's so relevant. And this is about PAs in hospitals, and it's because we've got
I knew you'd ask that.
Yeah, we've got a campaign on that at the moment, and someone's very kindly asked a question on this, so I just thought it'd be really interesting to get your view as well. So it's about both, well, local authorities, but obviously on your case, ICBs calling them double funding. I know you can't talk for the hospital side, but where a hospital is happy to have a PA and it's keeping that person comfortable, giving them continuity of personal care, can you see our side that we do not feel that is double care, or do you have a view on this?
I do have a view on this. It's included in our policy that we will consider funding when PAs are supporting individuals in the hospital, because we acknowledge that it's not just about the health needs, it's about the emotional and psychological needs. And what we do say is if that individual requires support from the PA in hospital, it needs to be stated in the care plan, because that is where we're going to see how that individual needs to be supported, really. So let's say that someone is admitted to hospital. You don't know how long it's for. You know, normally a week, 2. We will continue the funding, and we expect the PA to be providing that emotional and well-being support to the individual. However, they cannot be doing medical tasks, because that will go against the hospital's policy to do so. If the individual is planned to be in hospital for longer than 14 days, then our policy is to have an individual conversation with the employer to see how we can get to an agreement, because we appreciate that things might be uncertain, and we want to make sure that when that person comes home, they come back home for a team of PAs that they had before. So I'm not going to say that we stop funding, because we don't. It's about that individual conversation after the 14 days. I wouldn't look at it as double funding, but again, this is in our patch. And just as a quick example, we did have an individual that went into hospital, and they incurred extra expenses for the PAs too. Instead of going to the place where the individual lived, they went to the hospital, and it was very smooth because the ward actually offered to pay that instead of coming out of the PHB. So that's how it was arranged.
Right, okay, thank you. What about when you say no medical tasks? I know sometimes PAs are trained on very specific things like ventilators or I don't know, suppositories someone's put in the chat.
Yeah.
Where does the line, like, for example, that might be not anything to do with why they're in hospital, but something the PA is trained to do on a daily basis? What would you think about that?
But that is considered a delegated healthcare task. there is a team in the community that delegated that task to the PA to complete that. And when they are under the hospital care, they should be doing that. So that's the one thing that we say PAs should not be doing, the delegated healthcare tasks. But again, then there are the disclaimers of if there have been conversations between the hospital ward manager and the PAs, and it's been agreed between them, that's another story, and that's something that we're not privy to. But I would say not to complete it, because that would be against the hospital protocol normally.
And the last thing, sorry, still on the same topic. What if it's not in your care plan? Like, for example, I know it doesn't mention anything about hospitals in my care plan. I know it's direct payments, not CHC. What if it's someone who doesn't regularly go into hospital, but if they do, they'd want their PA with them? Can they contact the ICB to discuss that situation? Or does it have to be in the care plan already?
I would say contact your ICB to discuss it, and just say, you know, I'm aware that it's not there, but I've been thinking about this, and actually I would like my care plan changed to say this.
Okay.
I'm just seeing a lot of people going, so I just wanted to say thank you so much for coming and listening, and thanks so much. But you can carry on asking questions, Jane. It's fine.
Don't worry, that was the end of my grilling. I'm sorry. I know.
No, not at all.
On that dusted it.
Sorry, I
Sorry,
couldn't hear
what was
that.
that? I think that was an accident. But for those of you, there is still a few questions left, about 7 or so, I think, from memory. So don't worry, they will be answered. Anna will kindly complete them when she gets back from leave, and they'll be put on the website with the others. So I'm sorry we didn't get through them all. There was just so many, and so many interesting things to talk about. Particularly, thank you for our discussing the campaigns where we've got the hospital and the daily logs. It's just interesting to get your view on those. But overall, I just want to say thank you so much, Anna. We really appreciate you coming along. I know this isn't something you do often, I don't think.
No, it's not. So it was good to get out of my comfort zone. Thanks everyone for having me.
Thank you, and for giving up your time, putting all that time and effort into making the presentation, which is on the website, by the way, so everyone can access it. There's tons of information in there. But thank you so much.
Thank you, Jade, for organising. You're fab.
Oh, thank you.
Thank you, everyone.
Thank you. Thank you so much, everyone, for coming along. I really appreciate it.